Thank you, Mr. President. We are now entering a post-fiscal cliff phase of budget negotiations, and a troubling but familiar refrain is already beginning to echo through this chamber, which goes something like this: in order to fix our deficit, we must cut Medicare and Medicaid benefits. This is wrong. This is flat out wrong. It is factually wrong. It is wrong. A recent Providence Journal editorial touched on the dangers of that misguided approach. The editorial read, "We need a better run Medicare and Medicaid, not one that covers fewer people. Quality can be improved and costs contained without throwing people off the rolls and into the streets and back into the free care of emergency rooms mandated for the uninsured and into expensive private insurance. In the end, we all pay in some way, in quality of life and in money, for the gaps we tolerate in our healthcare system." Attacking Medicare and Medicaid is consistent with a particular political ideology. It has been part of that political ideology for decades now. But it is not consistent with the facts. It ignores the fact that our healthcare spending problem is system-wide, not just in federal programs. It ignores the fact that we operate in this country a wildly inefficient healthcare system. It's not just Medicare. For example, Secretary of Defense Robert Gates said in reference to the defense budget, "We're being eaten alive by healthcare." New data from the Centers for Medicare and Medicaid Services show that our national health spending increased to $2.7 trillion in 2011, which is about 18% of America's gross domestic product. This is more than 3 times what it was in 1992, and it's about 100 times what it was back in 1960. The presiding officer of the new Senator from Virginia and I were probably around in 1960. So in our lifetimes, it's gone up 100 times. At this rate, by 2020, 1 out of every $5 in this country will go towards health care. This is just a rocketing pace of increase. 1979, year after I graduated from college, $221 billion. 1987, $519 billion. 1992, $857 billion, and now $2.7 trillion. Anybody looking at that graph of our exploding national health care costs who can think that Medicare is the problem simply does not have a grasp of the facts. Let's compare U.S. spending to other developed countries. This is us, pre the last report, when we were still at 17.6% of GDP. The next least efficient developed country is the Netherlands, at 12% of GDP in 2010. Germany and France were at 11.6% of GDP. This margin right here, the margin by which we are more inefficient than the least efficient of our industrialized competitors, $800 billion a year. We could save $800 billion a year in our national health care system just by becoming as efficient as the least efficient of our national competitors. For all of this extra spending, the extra $800 billion a year, one might expect that we would have paid for and earned longer and healthier lives. But that is not the case. Our National Institute of Medicine recently compared the United States to 17 peer countries. We were worst for prevalence of diabetes among adults among those 17 countries, worst for obesity across all age groups of those 17 countries, and had the worst infant mortality of all 17 countries. We suffer higher death rates and worse outcomes for conditions such as heart disease and chronic lung disease. This chart from that Institute of Medicine report shows all these dots of the other countries grouped around cost, expenditure per capita, and life expectancy. That's the United States of America, the dot with the red circle around it. We are an outlier, below virtually all of these countries except Poland and Turkey and Hungary, below them all on life expectancy. They're all above 78, and we're just below it. And wildly out of the grouping on cost. We are way higher cost than the grouping of all of our industrialized competitors. We are wild outliers in a very bad direction of high cost and poor outcomes. This is a stark and unsettling disparity of us from virtually all the other nations, and it's not to our benefit. So the real issue here, the fact that we have to deal with, is the cost and the performance of our health care system. Another fact that I know the presiding officer is well aware of is how hard this is on American families. From 2000 to 2009, the average family premium for health insurance more than doubled, from around $6,500 to more than $13,000. I can assure you, Mr. President, the average family income did not double during that same period, unless maybe you were an average family on Wall Street. Healthcare costs are a leading cause of family bankruptcy in this country. Now, thankfully, the Affordable Care Act will help millions of uninsured Americans purchase health coverage. But we should add, in addition to the knee-jerk reaction to target Medicare and Medicaid being out of step with these facts, it will also hurt those families more without grappling with the real health care system cost problem. Again, going after Medicare is wrong. It is a misdiagnosis of the problem. And of course, when you miss the diagnosis, you prescribe the wrong cure. Medicare is actually one of the most efficient parts of our inefficient healthcare system. From 2007 to 2011, for the same set of health benefits, the annual growth rate in health spending per Medicare enrollee was 2.8%. For private plans, 5.6%, twice as much, a 100% higher cost than for Medicare. The Congressional Budget Office has found that for every dollar that we spend on Medicare, 98 cents of it goes through to people in the form of health care, actual health care. Spend a dollar, get 98 cents worth of health care. For Medicare Advantage plans, the ones that the private insurance sector runs that operate under similar rules and treat the same population as Medicare, every dollar spent delivers only 89 cents in health care, with the rest spent on administrative costs and CEO salaries and marketing. So not only is Medicare not the problem, it's actually one of the best ways we have for delivering health care through this wildly inefficient outlier of a healthcare system. I am not alone in saying that a correct diagnosis of the problem will lead us to health care system reform, not Medicare benefit cuts. Gail Walensky, the former CMS administrator under President George H.W. Bush, said in 2011, if we don't redesign what we're doing, we can't just cut unit reimbursement and think we're somehow getting a better system. Now, a lot of my colleagues give great credence to the private sector. In the private sector, one of the leaders in healthcare is George Halverson, who recently stepped down as chairman and CEO of Kaiser Permanente, one of the biggest and best healthcare companies in the country. Here's what he said. There are people right now who want to cut benefits and ration care and have that be the avenue to cost reduction in this country, and that's wrong. It's so wrong, it's almost criminal. It is an inept way of thinking about health care. So from Republican administrators to private sector leaders, the message is the same. We have to solve this as a system problem. Let me give a couple of examples of how you might want to go about doing this. As one example of the significant savings to be found in our healthcare system, a Washington Post columnist recently wrote, and I quote, "Few people realize that Medicare spends wildly different amounts per senior depending on where the senior happens to live. Medicare spends 2.5 times more per senior in Miami than in Minneapolis. 2.5 times more per senior in Miami than in Minneapolis. Yet there's no difference in quality or health outcomes associated with this extra spending. In other words, Medicare redistributes billions from regions where doctors practice cost effectively to regions where the local medical industrial complex pads its income with excess services and procedures." Our colleague Senator Franken often says, if we could just deliver health care the way we do in Minnesota, we could solve our problem. And this column and this information bears it out. If you're not getting better health care in Miami, then why do we tolerate letting Miami absorb 2.5 times the cost per senior than they're able to provide it for in Minneapolis? We should be driving Miami towards Minneapolis. We know they can do it in Minneapolis. Make that the model and force the change. This graph uses data from the Dartmouth Atlas Project to illustrate this point. Not only is there significant variation in healthcare cost and quality, each of these dots is a state, and they're rated on overall quality and spending per beneficiary. And as you can see, they spread out from very high cost and very poor quality states like Louisiana to very low cost and high quality states like New Hampshire. But if you draw a statistical line through this array of dots, here's the line you get. And it shows the reverse correlation. The more you spend, the worse your care. A second example, and that is consistent with this, is how poorly our healthcare system performs on basic measures of quality and safety and prevention. For example, according to the news magazine The Week, avoidable infections passed on due to poor hospital hygiene kill as many people in the United States, about 103,000 people killed every year, as are killed by AIDS, breast cancer, and auto accidents combined. We are killing more people in this country through hospital-acquired infection than through AIDS, breast cancer, and hospital-acquired and auto accidents combined. These deaths are tragic to those families, but they're tragic in another sense because they're preventable. As we've shown in Rhode Island, when hospital staff follow a checklist of basic instructions, washing hands with soap, cleaning the patient's skin with antiseptic, placing sterile drapes widely over the patient, rates of infection plummet, and the costs of treating those infections disappear. The costs of treating the 100,000 Americans who die every year from those hospital-acquired infections are huge, and they would disappear if we don't have the infections in the first place. And the cost of treating the hundreds of thousands who get those infections and don't die who aren't among the 103,000 who die but nevertheless have to be treated. Those costs also disappear. It's a pretty big number. We don't know exactly what it is, but the Centers for Disease Control and Prevention reported that from 2001 to 2009, there were state and federal efforts to prevent these hospital-acquired infections, and that contributed to a 58% decrease in the number of central line bloodstream infections among intensive care unit patients. That in turn represents up to 27,000 lives saved. 27,000 lives saved, and approximately $1.8 billion in cost savings to our healthcare system. Let's do more of that before we go after Medicare benefits. A third example is managing and preventing chronic disease. Compare the United States to France on the treatment of lung disease. And you'll find that although France has more smokers and therefore higher rates of lung disease than the US, levels of severity and fatality are 3 times lower in France. France spends 8 times less on treatment per person than we do. Compare the United States to Britain on diabetes. You'll find that Britain spends only half of what we spend per person on diabetes, but is 5 times more productive in managing diabetes than we are. Dr. Daniel Vasella, who's the chairman of Novartis, explains that, and I quote, "In America, no one has incentives to make quality and cost-effective outcomes the goal," end quote. France and Britain give their healthcare providers incentives to focus on early detection and cost-effective treatment that make wellness the goal, not treatment. To paraphrase George Washington University professor Thomas J. Schoenbaum, make virtue profitable and everyone becomes a saint. Saving money by reforming how we deliver health care isn't just possible, it is happening. A 2008 report from the Dartmouth Atlas Project predicted that, and I'll quote, "Using the Mayo Clinic as a benchmark, the nation could reduce health care spending by as much as 30% for acute and chronic illnesses." A benchmark based on Intermountain Health Care, which is a great provider based out in Utah, predicts a reduction of more than 40%. So we're doing it. It's happening. We just need to spread it more widely. During a 2011 Senate HELP hearing that I chaired, Greg Polson of Intermountain Healthcare said, and I quote, "Intermountain and other organizations have shown that improving quality is compatible with lowering costs. And indeed, high-quality care is generally less expensive than substandard care." Take a look at what various experts estimate as the potential annual savings that could be found in our healthcare system. The President's Council of Economic Advisors says that we could annually save $700 billion, $700 billion a year. Our National Institute of Medicine recently reported that we could save $750 billion a year. The New England Healthcare Institute has estimated that savings of $850 billion a year are possible, and the Lewin Group, a private group that focuses extensively on healthcare and does research and analysis, together with George Bush's Treasury Secretary Paul O'Neill, have come up with the estimate of $1 trillion a year. We don't know what the exact number is. These are estimates. But for sure, there is a huge potential for savings in our healthcare system. And these savings flow through to our federal budget. The federal government does 40% of America's healthcare spending. If the estimate by the Council of Economic Advisors is correct. Here we go. National healthcare expenditures, 2.7 trillion. Federal healthcare spending, 1.1 trillion. Do the math, it's 40%. So if you take, of those four estimates, let's take the most conservative one. Let's take the Council of Economic Advisors estimate of 700 billion, the lowest of the four, multiply it by 40%, and the federal share would be savings of $280 billion per year to the federal government. $280 billion per year just by getting those kinds of savings. Let's say that we can't get the $700 billion. Too hard to lift, can't get there, we tried. Let's say that we can only get halfway. We can only get half of those estimated savings. That's $350 billion. Times 40%, we could set a target of $140 billion of savings in the federal budget in health care, having assumed a 50% failure rate in getting there from the lowest of the four major estimates. That's pretty conservative to start from the lowest of the four major estimates, to assume a 50% failure rate, and there you are, you still get $140 billion a year that we could target as savings coming back into the federal budget and the federal healthcare system. So let's say we set the target at $350 billion, the halfway target, and we failed at meeting even that target. Let's say we failed again by half. Not close, a huge miss by half. And the best we could do was to get $175 billion of the $700 billion in savings that was the most conservative of those four estimates. By 40%, guess what? That's $70 billion a year. $70 billion a year. And what do we do when we get into budget discussions? We multiply by 10 because it's a 10-year budget estimate. So if you're going to take that $70 billion and move into a budget discussion, it becomes $700 billion. So this is real money. Let me add that most recently, the Commonwealth Fund released a report that outlines a set of distinct policies that would accelerate healthcare delivery system reform and slow health spending by $2 trillion over 10 years. Not just $700 billion, $2 trillion over 10 years, from 2014 to 2023. So how do we get there? Well, many of the tools necessary to drive down costs and improve the quality of patient care are already in the law. The Affordable Care Act, the famous Obamacare, included 45 provisions that have virtually never been discussed on this Senate floor because they weren't controversial, that were dedicated to redesigning how healthcare is delivered. These delivery system reforms cover 5 priority areas: payment reform, making sure that people are paid to keep you well, not to wait till you get sick and treat you more; primary and preventive care, making sure that we're taking better care of chronic patients, less specialists, more care up front; measuring and reporting quality, so we're not dealing with those hospital-acquired infections so much; administrative simplification, because if you're a doctor, you know that it is a bear to try to keep up with all the different insurance companies trying to deny you payment; and health information technology, so we have an electronic health record that loads with data and is sensible and state-of-the-art. These Affordable Care Act delivery system reforms span across our healthcare system, and they engage all stakeholders in the effort: patients, physicians, hospitals, state governments, and the federal government, which is good because working together is the right way to achieve these reforms. There is even evidence that the Affordable Care Act is already working to slow the growth of healthcare spending. In a Washington Post op-ed this summer, Secretary of Health and Human Services Kathleen Sebelius wrote, "In the decade before the law passed, national health expenditures increased about 7% per year. But in the past 2 years, these increases have dropped to less than 4% per year." though actually at the top of this graph, it's actually starting to tip down a little bit thanks to that. Dropping it to less than 4% per year has saved Americans more than $220 billion. Peter Orszag, the former director of the Office of Management and Budget, said the same thing in a recent Providence Journal editorial. He said, and I quote,
Need to begin to wrap up.
may I ask unanimous consent for an additional 2 minutes to finish my last.
Without objection, it's so ordered.
Thank you. I know that the distinguished senator from Alabama is waiting, and I'll wrap this up. Peter Orszag was the director of OMB, and he wrote in the Providence Journal, in January 2009, CMS projected that expenditures would reach 19.8% of gross domestic product in 2017. This year, the projection for 2017 is down to 18.4% of GDP. That difference amounts to a whopping $280 billion. In other words, relative to the projections issued 3 years earlier, today's forecast suggests health savings of $3,500 per family of 4 by 2017. I did this report for the Senate Help Committee last year on the Affordable Care Act delivery system reform provisions. If anybody is watching and wants a copy, contact my office. We will send you one or email you one. In this report, we found that the administration has actually made fairly considerable progress on the 45 delivery system reform provisions in the law. But much more can and must be done. Specifically, the report calls upon the Obama administration to set a cost savings target for healthcare delivery system reform. A cost savings target will focus and guide and spur the administration efforts in a manner that vague intentions to bend the healthcare cost curve will not. It also would provide a measurable goal by which we can evaluate the progress of the Affordable Care Act. The Commonwealth Fund, in the report that I mentioned earlier, has reported that, and I quote, the establishment of targets can serve both as a metric to guide policy development and as an incentive for all involved parties to make them effective. One of the best examples of a clear target was President Kennedy declaring that within 10 years, the United States government would put a man safely on the moon and bring him home. That message and the mission that was outlined was clear. The result was a mobilization of private and public resources to achieve that purpose because the goal was clear and specific. This administration has a similar opportunity, particularly now at the height of the implementation of the Affordable Care Act. Set a serious cost savings target for our nation's healthcare system, none of this spongy bending the healthcare cost curve stuff, and put the full force of American innovation and ingenuity into achieving that target. That approach has a triple benefit: protecting Medicare and Medicaid benefits that don't need to be cut if we're doing this right. Second, improving patient outcomes, making people healthier. And third, dialing back healthcare spending by potentially hundreds and hundreds of billions of dollars. The alternatives to that will harm seniors and those least able to afford adequate health care. So I conclude by urging the administration, set a real cost savings target, a number and a date. And then let's get to work to give the American families the healthcare system that they deserve. Instead of waste and inefficiency, instead of being a disgraceful outlier from all the rest of the world on quality and cost, let's make, for America, a healthcare system that is the envy of the world. That should be our goal, and that could be our destiny. I thank the presiding officer, and I yield the floor, and I express my appreciation to the distinguished senator from Alabama for his patience during my remarks.